Hello, everyone, and very good evening to all of you. So, this is Kapil Gautam signing as a host for the today's session. So, we are going to have a 128th session on iTalks webinar powered by Mero Academy. So, without further ado, let me start the today topic and today to give a short introduction about today speaker. So, we are going to have a session on role of vitamin D and outdoor activities on myopia. And as a speaking delegates, we have Miss Neha D. Chaurasia. She is an optometrist trainer on Lenskart, and she has done her master in clinical optometry, and she is currently pursuing her PhD at KwaZulu, Natal. And she had also done her fellowship from the FLVPEI on posterior segment. So I know you are too much eager to learn. So without being further ado, I'd like to hand over the today screen to the Neha, Miss Neha. Over to you, ma'am.
Thank you so much, Kapil. Thank you for that introduction too. So today I'm going to take you through a very interesting and very hot topic, I must say, that is the myopia control and prevention through vitamin D. Okay, so what is the role of vitamin D in stopping or preventing the onset of myopia? We are also going to talk about outdoor activities in detail. So I'm just sharing my screen. Kapil, am I audible and the screen is visible?
Yes, ma'am. It's
Yeah,
perfect.
thank you. So we have been talking about myopia, I think, day in and day out. As an optometrist, we see almost 30% of our population coming to our clinics, coming to our coming to the hospitals, coming to the optical outlets. Uh, almost 30% of our population as myopic, correct? Having a minus prescription, I must say. So today we are going to understand what is the role of vitamin D and outdoor activities in myopia. So before that, let me make you understand one of the factors or what is the prevalence. Let us know about what is the current prevalence and what is the predictable future of myopia in all over world. So according to a global prevalence survey done in 2016, which says that almost 28% of world's population suffers from myopia, which is equal to 1.95 billion people. And it is predicted that almost 50% of world's population will become myopic by 2050, which is equal to twice the number what we had in 2010, which is 4.76 billion people. And 938 million people are predicted to suffer from high myopia, which puts them at risk of more serious eye conditions. If you see the trend from 2000 to 2050, it has been in rise. So now, region-wise, if you understand the prevalence, it's if you divide what is the predictable prevalence in 2050 from the current prevalence rate, it is expected that on Western Europe may grow 28% to 56% by 2050 from the current rate of 28% of a myopic population in the country. North America from 34% to 58%, Southern Latin America from 23% to 53%, almost 50% of the population. Eastern Europe, Central Europe also may rise from 27% to 54% and 25% to 50%. East Asia, Asia Pacific, all are getting risen from 47% to 65%, twice the number, 50% to 66%, and Southeast Asia, 39% to 62%. Southern Africa from 8% to 30%. So, why it is a concern? Currently, we do have myopia control programs, right? Kapil, can you help me? I want to ask the audience a question if they can answer me, if it is possible.
Yes, ma'am, I can help you, but it will be a little bit delay streaming on the YouTube, so it
Okay,
might
okay,
take a little bit time, but I can include.
okay.
You know,
Okay, thank you. So before asking your question, let me take you through the onset of myopia. Generally, the development or the onset of myopia occurs in school age children. Agree? You agree with me? And the eye continues to grow during the childhood. It typically progresses until the age of 20. A child may need a stronger prescription as they continue to grow. And in today's world, where we are more online, the education has gone online, and we are more tech driven. We are in front of the computers, we are in front of our mobile phone. Children are studying, schooling is online, so everything is near, and in the near distance. Hence, there is a prediction that because of lot of near work, lot of exposure to these gadgets, it is expected that myopia may keep on rising. And in today we are seeing that, if you are an optometrist, if you're listening to me, you would have strongly related to it, correct? So we need to start analyzing and uh, correcting myopia at an early age, as early as 5 to 6 years of age. So now let us understand what are the preventive measures, or what are the treatment what we can give for myopia, or to stop down the myopia progression and to prevent the onset of myopia. So let us understand that. So what are the factors which are affecting myopia progression? You may agree with it. Hereditary. Hereditary is one of the causing factor which builds up or which adds up to myopia progression. Then you have outdoor activities. Now, outdoor activities is one of the leading factor which we are going to talk about in the further slides. Near work. Near work is strongly associated with myopia. Higher educational attainment. The research studies done on education and myopia says that students who are excelling in their exams, who are academically strong, are they tend to have higher level of myopia, or the prevalence rate is higher in highly educated children. Socioeconomic status, body stature, degree of urbanization. Now, urban kids or urban kids compared to rural, if you study, myopic development is more in urban kids compared to rural children. Why? Because they have a lot of near work. Again, level of physical activity, it has been studied that people who are having a lot of sedentary lifestyle, people who are at home sitting, not having physical activities, are tend to be more myopic compared to people who have a lot of physical activity. So physical activity adds up to myopia. Less of physical activity, low birth weight is said to have children who are born with low birth weight may tend to have myopia. Parental smoking status, if the parents of the child are were had an history of smoking, their children are at a risk of developing myopia. Parental education, highly educated children may have myopic children. Family history, yes. Children with both the parents myopic are at 50% risk of developing myopia. So now that we understood the factors which are affecting the myopia progression, let us understand how do we control it. So myopia control program involves or specialized contact lenses like orthokeratology, multifocal contact lenses, medicated eye drops like atropine, multifocal spectacles, and lifestyle modifications. So, how many of you agree with me that what are the cost factors? Kapil, I wanted to ask the question to the audience that what is the cost involved in myopia control, and how many of you start a myopia? What is the first line of treatment you give to myopic kids, or myopic whoever comes with having first time myopia children, specifically. So I want to ask the optometrist here the question: what is the first line of treatment you give to a myopic kid? So if you can help me with the answers, Kapil.
Okay, ma'am.
Yeah.
So let me wait for the few seconds.
Responses. Yeah.
Yeah. So I like to request all the attendees, what are the primary or first thing you do for the myopia control or myopia treatment when any patient have the any patient you have on your clinic?
So I have already given some of the treatment plans, but what you start with, in your clinic, do you start with uh, spectacles? Do you start with multifocal contact lenses, or do you start with atropine, or do you refer the child to ophthalmologist, or do you start with normal single vision glasses, or do you start with progressive like multifocal lenses or contact lenses? Are you getting any responses, couple?
No, ma'am. No, ma'am.
Yeah. Okay. So we'll wait for 1 minute more if there are any responses.
Okay.
Okay. So any responses, couple? Okay.
No, ma'am.
So
Still no.
let the responses come in. We'll try to understand what are the costs involved in these myopia control programs. So I wanted to highlight here is once a person gets myopia, and when it shows a progression of myopia, you need a myopia control program. Why myopia control? Because if it progresses, it will lead to other comorbidities like pathological myopias like staphyloma, macular degeneration, myopic macular degeneration, retinal detachments, and a child may lose its eyesight, which is crucial. So, my, myopia control program is important to stop out the progression. But if I tell you we can prevent it from development, why don't we try preventing it? So let us understand the cost involved in myopia control. So cost involving the treatment, if you go with a myopia, usually the myopia control programs will have a combination of treatment with autokeratology. You will also have to start with low dose of atropine, may require surgery in some cases like retinal detachment or macular degeneration and so on. Multifocal contact lens, multifocal spectacles for myopia and other treatment options. So if you see approximate cost of myopia eye drops is $2 to $5 per 5 ml bottle, and they may require it for 4 or 5 years. Orthokeratosis lenses is $201 per lens. Surgery involves $1,000 approximately and may require more. Multifocal spectacle lenses for one lens, it is $134. So if you see approximate cost is too high. So hence we need preventive measures to control it and prevent it from development, right? So can we prevent myopia development? Oh, COVID-19 taught us a lot. Prevention is better than cure. So if we prevent myopia from occurring, we will prevent from the comorbidities and high cost of treatment involved in myopia, right? So what is the preventive measures? What you can do? It's very simple. So let us understand the role of vitamin D and outdoor activities on myopia. So according to studies done, they say that myopic participants had significantly lower level of vitamin D3 concentrations. So in a study where myopic and normal kids were taken, they found out that myopic kids have significantly higher levels, significantly lower level of vitamin D. Myopic kids were vitamin D deficient compared to individuals with sufficient levels, if you see. So compared to normal kids, myopic kids were vitamin D deficient. So there are many possibilities and studies that are underway to help determine what is happening. So what is happening? Sun exposure helps to increase the vitamin D production, and that's what your outdoor activity does. Outdoor light stimulates the production of a factor in the retina, which is dopamine, which is a chemical messenger for light adaptation in the eyes. which can help slow down the eye growth. Exposure to visual opportunities for distance and to relax the eye muscles at the same time. So, what does the dopamine does in eye development? Dopamine has been recognized as a candidate in eye growth regulation, with evidence suggests that dopamine release is reduced under condition that increases the eye growth, that is the axial length growth. Increase in dopamine suppresses the axial length growth and prevents myopia. A study was done on guinea pigs where 58 guinea pigs were randomly divided into two different groups at the age of 4 weeks. A normal, a control group where and other group where they had done an occlusion. Okay, form deprivation was created, induced with a translucent eye shields over one eye of a guinea pig, whereas the other eye was kept open. So they found after 10 days of occlusion that corneal curvature, refraction, and axial length were measured, and they found that form deprived eyes elongated and became myopic. Retinal dopamine decreased, but the corneal radius of curvature was not affected, but axial length had grown and the eye had become myopic. Whereas the other eye or the animals with no occlusion did not show any decrease, any increase in the axial length, and they didn't show any kind of refractive error. So 10 days of occlusion resulted in caused the affected eyes to elongate and become myopic in guinea pigs. But the level of dopamine they injected in the eye in the unoccluded animals had no effect on its ocular refraction. So this experiment concluded that dopamine does play an important role in eye growth and axial length development. Now, what is the relation of dopamine with vitamin D? Now, vitamin D has many roles in our body, as you know, muscle strength, cognitive function, memories, and so on. And it also regulates a neurotransmitter like dopamine. A study done on mice evaluated that there was an increased level of dopamine in the blood when supplements of vitamin D3 was given on the mice. However, both the studies were done on animals and no human interventions were done. I had, in my master's, when I was doing my master's program, I had done a small experiment where I studied a school going 8 children. I enrolled school going 8 children between the age of 11 to 15 years. All participants were asked to fill a detailed myopic questionnaire. I will show you the questionnaire at the end of the presentation. We also evaluated the level of physical activities using an Omron pedometer device, and vitamin D analysis was done using a rapid vitamin D testing strips. Now, out of 105 children who were enrolled in the study, I found the mean refractive error which was included was minus 2.35 diopters with a standard deviation of 1.83. However, only 20 children agreed to wear a pedometer device. And we found out that out of the total population, there was a 50% division between emmetropes and myopes. 49 were found to be emmetropes, 56 children were found to be myopes. Females, we had a more male to female ratio, more males than female. So males, we had 58 males versus 47 females in the study. In the questionnaire, actually, I asked 20 different questions according to their lifestyles, like sleeping hours, reading for pleasure, computer, TV, movies time, hours spent on sleeping, hours spent for reading, hours spent on computer, TV, movie watching, reading for study, sports or exercise outdoors, total outdoor time, total indoor time, reading for pleasure on a holiday, total outdoor holiday time, and exercise indoors. What I found was myopic kids slept lesser than emmetropes. So they slept 1.5 hours lesser compared to emmetropes, which was found to be clinically significant also according to the study. So myopic kids slept for 6.5 hours, where an emmetrope or a normal kid slept for 7.5 hours, 7 hours 15 minutes, and on an average. Also, reading for pleasure, myopic kids read more, that almost 1.5 to 2 hours, compared to emmetropes who read only for 30 minutes or so. It's a mean average time, which was again found to be clinically very significant. Again, you talk about the total outdoor activities on the holiday, on a leave or a holiday period. Myopic kids had a lesser outdoor activity time, which is much lesser, 0.1116, that is 15 minutes almost approximately. Whereas emetropes spent good 2 hours in sun outdoor, and which was again found to be clinically significant. Then exercise indoors, we also found that it was though it was not much of a difference between an emetrope and a myope, but it was found to be clinically significant. So myope had lesser activity indoors compared to emetropes. Okay, now let us understand the 20 children who actually agreed for a objective experimental study experiment where we actually analyze the physical activities. So we actually go back to our previous slides where where we understood that physical activities has an influence on myopia, correct? So I gave them a pedometer device, which is like a normal which calculates your average sedentary time and average active time and steps also. So we found out that average time spent by myopes doing near activities was 3 hours per day average, compared to 1 hour per day by emetropes. So emetropes really read very less compared to myopes, and myopes spent less time outdoors, that is 30 minutes per day on an average, where compared to emetropes, which they spend 2 hours per day. And average steps taken by a myope and emetropes were myope took 6,167 steps, whereas an emetrope took 7,117 steps respectively. So myopes walked less compared to emetrope. However, we had included 20 children. We need a more sample population for this. Now, I also experimented with vitamin D3. Okay, with the help of rapid vitamin D3 testing strips, we could do vitamin D3 analysis on children, where 16 children and 16 parents, parents of 16 children agreed to participate in the study. We found out that out of 16 children altogether, 8 were myopic and 8 were emetropes. All 8 children who were myopic, like 100% of myopic children showed vitamin D3 deficiency, whereas 37.5% emetrope showed deficiency of vitamin D3, and 62.5% emetropes had normal vitamin D3 values. So this clearly tells us that vitamin D3 levels of vitamin D3 is lesser in myopes compared to emetropes. Now, I also, during the course of my experiment, I had got an opportunity to work with a 14-year-old myopic child who was one diopter myopia at an age of 12 years and showed a progression of one diopter per year. So he always showed a one diopter increase in myopia. So I did a vitamin D3 analysis where the levels were found to be 9 nanogram per ml, that is found to be deficient. Then we recommended lifestyle modification and prescribed vitamin D3 supplements with the help of the general physician for 6 months. Now, after 6 months, when we analyzed him, we found that there was an increase in vitamin D3 level from 9 to 14.1 nanogram per ml and had shown no myopia. So this lifestyle modification had a clear-cut indication. So let us the observations were as follows. Myopes spent less time outdoors compared to emetropes. Physical or outdoor activities were found to be associated with refractive error. Myopes spent significantly less time engaged in outdoor sports activities. Prevalence of myopia is was found to be higher in children with vitamin D deficiency compared to children with normal level of vitamin D or normal children. Low levels of vitamin D is associated with less exposure to sunlight due to reduced outdoor activities, sports, or exercise outdoors. Our study showed that all myopic children who spent less time outdoors were vitamin D deficient. Increasing outdoor time may prevent onset of myopia in these children. Myopic children spend considerably more time doing a near work activities such as watching television, mobile phones, computers, TV screens as compared to emetropes. So I conclude that increasing near activities, less outdoor time, decreased outdoor sports or exercise, low levels of vitamin D, and increase in mobile phone use were found to be a risk factors in myopia onset or development. So what we do? So let me explain you. This was a conclusion part of my study altogether. However, there were some limitations like less of sample size, and we need to do experiments, more of experiments on human population too. So in my study, I did a vitamin D3 analysis. What you can do when you start with myopia analysis, when you see a myopic children or myopic kid having low dose, having as low myopia as -1 diopter, you can do a vitamin D3 analysis with the help of rapid vitamin D3 analysis kit, which is very quick. It gives you results within 10-15 minutes. So what is the normal vitamin D level, and when you say it is a deficient? So according to Vitamin D Council, uh, deficient is said to be when there is a level of 0.30 nanogram per ml. Insufficiency is when 31 to 39 in between, and sufficient level is said to be 40 to 80 nanogram. Toxic, like high of vitamin D when you have more than 150 mg. So we have to aim for 40 to 80 nanogram. Okay. However, testing laboratories recommend deficient when it is 0 to 31, and 32 to 100 is found to be sufficient. Okay. Then we have to really count the steps of our kids, of the children who are myopic. And so with the help of a pedometer or advanced devices like you have in the mobile phone also, now we have applications which count our steps. So pedometer is the recommended one, and the Omron pedometer has been used in different studies. So I would suggest that go for an Omron pedometer for your kids. So when it is said to be sedentary, when you have less than 5,000 steps per day, 5,000 to 7,499 steps is found to be somewhat active. 7,500 to 10,000 is active. 10,000 to 12,499 is said to be active. And more than 12,500 is said to be highly active. So if your child has a sedentary lifestyle, start their physical activities as soon as possible. Then going to the natural sources of vitamin D3, if you see the costing of myopia treatment, which is so high, and you can go as low as the natural sources which is available at your house. So vitamin D3 sources are sunlight. Sunlight is the most important source, and morning exposure to sunlight is very, very, very important. I would suggest that if you are in a lockdown period, if you are stuck at home, take your child to your terrace, expose your children to the sunlight in the morning, which is very important. Then fishes are a great source of vitamin D3. Cereals, butter, cheese, whole grains, and milk. Then what is the daily recommended value as per age from birth, from 12 months birth to 12 months of age? That is 400 IU unit. Then international units, what we say. And children between 1 to 13 years require 15 mcg of or 600 international unit of vitamin D3. Adults, teens from 14 to 18 years required 15 again. Adults 19 to 70 years required 600 IU. Adults 71 years and older may require 20 mcg, 800 IU. Pregnant and breastfeeding women may require 600 international units of vitamin D3. Okay, so these are the recommended values. I would suggest please talk to your general physician. If you are deficient, please get your vitamin D3 supplements as soon as possible. So my take home message for everybody will be: exposure to sunlight is necessary to increase the level of dopamine in the blood. 45 minutes to 2 hours exposure to sunlight is recommended. No to minimum exposure to mobile phone or near gadgets. Diet rich of maximum proteins, moderate fats, and minimum carbohydrates. So these are my references, and I would like to end my presentation with a thank you to you, and I'm open to any questions or discussions. Over to you, Kapil.
All right. So thank you so much, ma'am, for such a wonderful session. I must say that this is the most essential topic, especially where most of the people are in lockdown. So once again, thank you so much. Now we are moving to the discussion session. So I'd like to see a few of the questions that raised by our audience on the YouTube. So let me share the screen. All right. So maybe, okay, all right. So you can see the questions, man.
Okay. So for the primary treatment of myopia, if you talk about, so it is basically you need to have a combination of treatment first of all, but single vision glasses is not a primary treatment. You have to start with orthokeratology or low dose of atropine. Yeah, sorry, for myopia progression we start with low dose of atropine, but for primary treatment it depends on amount of myopia. See, in myopic children we have there is an axial length growth. We need to understand the axial length and the corneal curvature and everything, and we need to start with a if you can start with orthokeratology or multifocal contact lenses or multifocal glasses spectacles are said to be the primary treatment for myopia patients. So it has to start with orthokeratology. I will show you a myopia treatment, uh, you know, a chart where you, if there is amount, how much amount of myopia is there, and what treatment to go for. But the primary treatment you need to start with contact lenses. That is orthokeratology. Okay.
Okay. So, all right. So here is the second question.
Okay, as a baseline treatment, we'll prefer cycloplegic correction for constant use. In order to record the progression, we'll call for follow-ups 6 by 12, and depending on that, we'll try penalization, contact lens, and ortho-K. So this is the answer somebody has given. Yes,
Mm.
so cycloplegic, see, for every kid, every growing kid, before prescribing any prescription, we need to get a cycloplegic refraction done to uh, to relax, to avoid any kind of accommodative errors, or if somebody, because children tend to accommodate more, correct? So for the relaxation of accommodation, it is required for for a cycloplegic correction. And yes, because we need to create there is an hyperopic defocus because of which myopia is there. So we need to create that, and we need to give them a constant we give them the correction according to it. So we need to start with a low dose of atropine. That is for progression. Okay. So if there is a progression of one diopter and above, then we start with low dose of atropine. That is the myopin eye drop 0.01% available. Then we give on the low vision, on the low dose of atropine, we correct them with multifocals, glasses, spectacles, especially the progressive lenses, or specialized contact lenses made, multifocal specialized contact lenses, and orthokeratology for the myopia treatment. Okay, I hope this is clear.
All right. So, Rikesti, can you? All right. So here is the another question.
Yes, any patient with convergent squint and having myopic refractive error, how can such patients be given spectacle correction? Uh, so basically, for myopic, if somebody has a binocular vision anomaly, right? So if you, I want to, after the question, I would want to show you something, on myopia protocol which we had developed. So we had to, for every myopic kid, you need to analyze their refraction. You have to do a cycloplegic refraction. You need to do a baseline refraction, then a cycloplegic refraction, then give the prescription accordingly. And also you need to understand the binocular vision status. And as per the binocular vision status, you give them treatments, for binocular vision. Like if they have a squint problem, or if they have a convergence problem, you give them vision therapy along with the myopic corrections, along with the spectacle corrections. What we have, we cannot give them a single vision glasses altogether. If required, we can give them prisms also, right? So convergence, squint with a myopic refractive error, and how much progression it is, we need to see all that. We need to analyze their we need to understand the binocular vision status. That we need to understand the cover test, what is do a binocular vision evaluation altogether, like Medox rod, cover test, NRA, PRA, everything we need to understand, and give treatment accordingly. Suppose they have a convergence squint, they have binocular vision anomalies, vergence problem, or vergence dysfunction, or divergence, or convergence, or a convergence insufficiency. You need to give them treatment on that first with the glasses. Correct? Only glasses may not help. So we cannot give them spectacle correction there and there without treating their binocular vision status. So we need to treat them first, and along with it, give a myopic correction also. So it will go hand in hand. Your myopia control and your binocular vision will go hand in hand, because sometimes you develop myopia because of accommodative spasm, or because of over accommodate lead of accommodation you do when you do a MEM test. You understand that. So what is the reason of myopia? If it is binocular vision, then you need to treat the binocular vision first, and then and with it you need to, in coordination, hand in hand, you need to give the treatment with it. So I think, Ajaz, if you like, I think I've answered your questions. If yes, you can tell me yes, or you want more explanation on it. You've understood this?
All right, so maybe I include his answer,
Yeah,
his response,
yeah,
just after the few questions.
yeah.
So, Miss Neha, can you please specifically, tell about the accommodation and how accommodation is related with the myopia progression?
So basically, if you accommodate more, so let me show you something which will help you understand it better. Just give me a second.
Okay, so Rikishi, can you please unshare your screen? All right. And yeah, ma'am, I guess you are muted. Neha, ma'am, I guess you are muted.
Just a minute.
Okay.
So let me just make you understand about this first, how you go with myopia treatment. Okay. So here you see what is the age of an onset of myopia. If the age is less than 10 years old and myopia is more than one diopter, and the progression is more than zero point 0.5 diopter per year, so you have to go with myopia control strategies like optical corrections, optical plus pharmacological, and lifestyle management. So, and if age is more than 10 years and equal to 10 years, or myopia is less than -1 diopter, progression is less than zero point 0.5 diopter per year. So if it is high risk, you have to go with myopia control strategy. And if there is no high risk, you have to go with lifestyle management. So that's what myopia control strategy is. Now, talking about, if you talk about accommodation, so accommodation is a big topic in myopia. Uh, when you accommodate more, okay, myopic kids do have a break of accommodation. When a lot of myopic kids who are studying right now, you ask them or you analyze them, they will be telling you that they lack concentration. They lack concentrating when they're reading full time. They feel that they have symptoms like headache and blurring of vision and like that. Now when there is a blurring of vision after prolonged near work or prolonged working on the screen, so you immediately catch up that there is an accommodative problem. Now accommodation may, when you relax when there is a lot of accommodation is used so much that there is a block or spasm of accommodation happening, because of which immediately when you look at distance it is not clear, suddenly it is blur, and then you try to make it clear. So it happens when your lenses accommodate too much. Now in myopic kids, when there is an accommodative problem in the eye, you analyze it with the binocular vision status first, that whether you do NRA, PRA, you do an MEM test, and you find out that if there is a lead of accommodation, they are accommodating too much. So they require more minus to relax, or sorry, they are accommodating too much, because of which now they are not able to accommodate. There is a spasm. Okay, there's a block of accommodation. So because of this, now they're not able to clear out their near vision properly. So you need to stimulate that accommodation, giving more minus, and they may require more minus. Okay, and that's why sometimes you have in the clinic you have pseudo myopic cases where uh, where you do a cycloplegic, where once the once the patient comes, and you see -3 -4 in the AR, and after a while when you do a cycloplegic refraction, relax their accommodation and check, there was no myopia, there is hardly -1 or zero point 0.5. So this accommodative status leads to more of myopia. So that's how your accommodation adds up to the myopia. I hope this answered the question.
Yes, ma'am. Thank you so much for making us so much clear.
Yes,
So
thank you.
once again, thank you so much, everyone, joining to us. So I'm going to drop a review and feedback file. So maybe I can request to our IT engineer, Rikesh, can you please drop the feedback file links on the YouTube live? So once again, thank you so much, Neha ma'am, for such a wonderful session. So it's a completely different. I guess the topic is completely different from the what we expect and usually talk about in the myopia, myopia scenario or myopia, in myopia symposium or other points of view. So once again, thank you so much. If you have any good notes to share with us before ending the today's session.
Okay. Thank you so much, Kapil, once again for giving me the opportunity and the Mero group altogether to give me an opportunity to talk on myopia. So we always talk on myopia control and big treatment plans. We need to give them autokeratology. We need to start multifocal contact lenses. But why don't we prevent it from happening? And this is, I think, vitamin D plays a significant role. I would end by saying that concentrate on vitamin D, analyze vitamin D on each and every myopic kid, and give them lifestyle modification along with other treatment plans altogether. And you will see a significant reduction in myopia, and you would save a lot of myopic comorbidities or pathological myopia happening. So I think from tomorrow onwards, or from now onwards, we need to think about prevention, and prevention is better than cure. Correct? So thank you once again for giving me the opportunity to talk to all of you. Thank you so much.
Thank you so much, ma'am.
Thank
So
you.
thank you so much, everyone, for joining to us. And I'd like to also, once again, thank you to Miss Neha, ma'am, for giving a totally new insight to us. Stay safe, stay connected. Thank you so much.
Thank you so much.